everybody. I think we're about ready to start. A minute or two late, but I think that's allowed. So, welcome everybody to our first Health and Wellbeing Board of 2024. I hope everybody had a lovely Christmas and Happy New Year to everybody. For people who haven't attended before, whilst this is a formal meeting, I try to run it as informally as possible, which means that everybody who's present has the opportunity to comment, ask questions, whether you're a formal member of the board or not. And we always start the meeting by introductions, so we know who's here. So for people that don't know, I'm Councillor Rachel Blake. I'm the Cabinet Member for Children's Social Care and Equalities, and I'm also Chair of the Health and Wellbeing Board. For people that haven't used the chamber before, it's just the big red button that you have to press when you want to speak, when it's your turn to announce who you are, and then please make sure you switch it off as well. So we'll go this way with Jonathan.
Morning everyone, I'm Jonathan Goodroom from the Council's Governance team.
Yeah, good morning everyone, I'm Richard Parker, I'm Chief Executive at Doncaster and Bassett Ward Teaching Hospitals.
Morning everybody, I'm Anthony Fitzgerald, I'm Executive Place Director for NHS South Yorkshire and I'm the Vice Chair of the Health and Wellbeing Board.
Hello, good morning everybody, I'm Councillor Nigel Ball, Cabinet Member for Public Health, Culture, Leisure and Communities. Thank you.
Hi, I'm Fran Joel, I'm Chief Operating Officer of Health Watch.
Hi everyone, I'm Councillor Sarah Smith, Cabinet Member for Adult Social Care.
Morning all, Nabil Al-Sindi, I'm a GP and I'm Medical Director for Doncaster in the ICB.
Morning everybody, Lee Galtz, AD for Children's in the Council.
Morning everybody, Louise Robson, Public Health, City of Doncaster Council.
Morning everyone, I'm Glynis Smith, I'm a Hatfield Ward Councillor and the Chair of Health and Adult Social Care.
Good morning, I'm Councillor Leanne Hempshaw, Roman Ridge Ward and the Chair Children and Young People Scrutiny Panel.
It's like some kind of game show, isn't it? Who's going to buzz in next? I'm Lucy Robertshaw, I'm the Director of Arts and Health at Darts and I'm here to represent the Health and Social Care Forum.
Hi, Caris Williams, Public Health Coordinator in the Health Determinants Research Collaboration.
Hi everyone, I'm Susan Hampshire, I'm Director of the Health Determinants Research Collaboration.
Good morning, I'm Ruth Bruce, I'm the Doncaster Place Development Lead.
Good morning, Claire Henry, Public Health Principal here at Doncaster Council.
Morning, Marie Rogerson, Public Health Registrar here at the Council.
Morning, Natasha Mercier, Public Involvement Community Engagement Lead within the HDRC at the Council.
Morning, James Woods, Chief Executive Citizens Advice.
Morning, Hayley Waller, Policy Insight and Change Team at Doncaster Council.
Good morning, I'm Rachel Leslie, I'm the Acting Director of Public Health at Doncaster Council.
Morning, I'm Phil Holmes, I'm the Director of Adults Wellbeing and Culture in the Council.
Colleagues at the back, you're very welcome to join in. You don't have to sit at the back if you'd like to. You don't have to introduce yourselves if you don't want to, that's fine, but rather than just sit there. Lovely. Okay, so we've received apologies for today's meetings from Dr. Rupert Suckling and Dave Richmond and Rhianna Nelson, and we have obviously substitutes with Rachel Leslie and Lee Galtz as well. And welcome, James. This is your first meeting. James is not yet a formal member of the Health and Wellbeing Board, but we recognise the huge contribution that CAB make to this agenda. So really pleased that he's now going to become a member. And as I said, just contribute as you want to, as though you were a formal member, James. Cynthia, welcome. Would you do an introduction? Do you just want to say who you are? And use the intercom situated in the left-hand side of the lift doors to call for assistance. The designated assembly point is the public square in front of Cast beyond the fountain. I would like to inform any members of the public and press that today's meeting will be audio-visually recorded. By entering the council chamber, you accept that you will be recorded and your image is retained and broadcast by the council on its website and on YouTube. If anyone intends to record or film any part of today's meeting, please ensure that this does not disturb the conduct of the meeting and you only focus on recording those people participating. So item 2 is Chair's announcements. Just a very brief announcement for me. As we go into 2024, very aware of all the pressures that all organisations are facing, but really hoping that all organisations will continue with the excellent partnership working that we have. I think, you know, when we're looking at budgets, etc., it's always so easy to think about things like prevention, supporting carers, supporting the voluntary and community sector as something that, you know, perhaps we don't always prioritise, but I would really encourage everybody as we move forward in 2024 to carry on the excellent work that we've had. Thank you also for your contributions to the Fairness and Wellbeing Commission. That was huge, and I think we've got a huge opportunity and responsibility this year to make sure that we start to take note of those recommendations and really see a step change in health and wellbeing and how people in Doncaster are supported to live the lives that they want to. Thank you. So item 3 is exclusion of press and public. There are no items on today's agenda where the press and public are to be excluded. And then item 4 is public questions. This is a standing item on board agendas aimed at providing an opportunity for some members of the public to ask a question or make a statement. Please note that questions or statements should relate to an item of business on the agenda for today's meeting. So are there any elected members or members of the public attending today's meeting who wish to put a question to the board? Thank you, Leanne.
Thank you. I've got a bit of a statement and then a few questions, probably to Richard Parker. Thank you. So, my mum died unexpectedly 7 years ago today. She had a benign tumour on her parathyroid gland, which is the size of a grain of rice. This caused her calcium levels to rocket. She was admitted to DRI 3 times during a 7-week period. Each time it would take about 5 days to flush the calcium out, leaving her unable to walk or talk and effectively comatose. The final admission, my mum's calcium level was 4.3. We were told at the time that this was the highest ever recorded in Doncaster. Her condition was described as life-threatening, and yet the surgery she so desperately needed was considered elective surgery. And she must wait for the head and neck surgeon in Doncaster and Bassetlaw to return from his 4 weeks leave. As a family, we would have taken her anywhere in the country for the surgery, yet no alternative was found. If someone dies in prison, they automatically get an inquest, but we had to fight for one and wait over a year. The inquest confirmed that the cause of death was pulmonary embolism due to hyperparathyroidism. In simple terms, a blood clot caused from being inactive due to being bedridden for several weeks, waiting for an elective surgery. So I've got 3 questions. The first one is, do we still only have one head and neck surgeon that covers Doncaster and Bassetlaw? And if they went on leave, would it be covered? That's the first one. The second one is, Richard Parker told the board at the last meeting that workforce challenges remain. Can I ask how many vacancies do we currently have at DRI, and has this improved within the last 7 years? And the final question is, does Richard Parker agree with me when I say people have died due to austerity in Doncaster? Thank you.
Yeah, thank you very much for the question. I'm sorry to hear about your mum. If we take the sort of questions in the order that you've given them, so within each specialty, and there are multiple specialties within any acute hospital, the actual staffing can vary for a number of reasons. It can vary, as you've indicated, by specialism. So if the actual presentation that patients appear in hospital with is a relatively small, then as you would probably anticipate, we won't necessarily have multiple specialists who will deal with that immediately available. And that's why we work as a system. So for special treatments, that's often provided at tertiary centre, Sheffield Teaching Hospitals. So across South Yorkshire, we would normally be able to produce the capacity to deal with urgent operations, and operations are classified on the needs of urgency. So for instance, during the most recent period of strike, which people will be aware of, most acute trusts would concentrate on life or limb-threatening surgery as the first priority. The second would be urgent surgery, and the third would be more routine surgery, and each one of them has a target date by which we would normally operate. So if a case is classified as routine surgery, non-urgent surgery, then it is dependent upon the waiting list and the capacity that specialties have, which did increase significantly during the COVID pandemic for reasons I think the public would know about. So giving an answer to a question about do you have a surgeon to do a particular procedure, well, that really does depend upon the procedure, and we would have to, give the numbers by individual specialty. But our ENT department, our neck department, does work in partnership with the tertiary centre in Sheffield primarily and firstly. So if a surgery is urgent and a surgeon was absent for sick leave, for instance, we would normally talk to Sheffield or one of the other partners to try to make sure that surgery is done in a timely manner. And if we haven't looked into your mum's case, then even though it is, in essence, by the date she can be out of time, be very happy to look into it for you. I think your second question was about vacancies, and the answer is similar in that the vacancies are dependent upon the staff group. But within very small specialties, the ones that I've already referred to, it does depend upon things like training numbers, and it also depends upon the attractiveness of the specialty. So depending upon which service you are interested in, we would have a different vacancy rate. The general vacancy rate for Doncaster and Basildon Teaching Hospitals is about 9% this year, so roughly speaking, 1 in 10 of our funded posts would be vacant, but that can vary. So if we have, for instance, a team of 4, and for whatever reason someone leaves, the vacancy rate will be 25%. So I would always caution against judging vacancy rates by percentages, because actually the numbers become important, as does the workload, because it's obviously dependent upon the size of the number of patients waiting. But we have got some very tricky areas. So if you take midwifery across South Yorkshire, there's a varying rate of midwifery vacancies, but recruiting midwives is a challenge. If you take histopathologists, the people who read slides, we've talked to you many times about that challenge. If you were to look in Sheffield, then they're almost fully established. If you look at Doncaster and Barnsley and Rotherham, then we've got significant vacancy rates, because actually colleagues are choosing to work in specific tertiary centres as a result of issues. So again, if it's particular specialties, we would have to give the number as well as the percentage by specialty. But vacancies in small areas of clinical practice is hugely significant. And even if there was as much money in the world as we wanted, then in some specialties we would not be able to recruit clinical colleagues for reasons that we've touched on. I think your third question about austerity, then I think that the challenges that the country has and locally, and we've got presentations later that would describe some of the impacts of austerity, then yes, austerity has had impact on the public health. It's had impact on our ability to deliver some services. But the fundamental thing that made the biggest difference was the impact of COVID-19. Now, COVID-19 impacted differentially, and so the most deprived in our communities had the greatest impact. So again, you would have to say that, yes, austerity, even with things like COVID-19, played a significant part and continues to play a significant part, because as we went into the pandemic, we didn't have significant numbers of patients waiting longer than 18 weeks. We emerged from the pandemic with significant numbers of patients, particularly in specialties like orthopaedics, waiting 104 weeks. So clearly we are in a position of recovering that. But of the 3 points, yes, all 3 points are relevant to current day NHS practice and clinical care. And if you do wish to have specific answers in respect of your mum's care, as I said, just provide me with the information, and we'll obviously do our best to provide you with robust and open and honest answers.
Thank you. I don't need you to do that, because we already went through every process that there is. We went through PALS, we went to the Ombudsman, MP, inquest, We met with the doctors. We did everything. And just on your point with saying about Sheffield, we asked about Sheffield, but we're told that they only deal with cases that are cancer. So because it was a benign tumour, that they wouldn't see her. And just in relation to my first question, I'm not really sure you quite answered that. Do you know if we've only got one head and neck surgeon currently, and if he was to be off or it was he at the time, would that post be covered?
So I can't give you the details because I don't actually know what surgery your mum was waiting for. So you can have general surgeons as well as specialist surgeons, and surgeons will do a range of procedures. So I'd have to actually go away and look at what surgery your mum was waiting for, because people's description of it sometimes is slightly different to the clinical and technical terms that the operation requires. So if we have an individual single surgeon, then it's not good practice for surgeons to work in that way. So what we would normally do, and again I'd have to confirm, is work with a tertiary centre like Sheffield to make sure that there is appropriate cover, and also that the surgeon was doing enough procedures in the year to make sure they maintain their clinical practice. Because if it's a limited number of cases that present, what you actually want to do is make sure your clinical colleagues have got exposure to that on a regular basis. So I'd have to know the procedure and check the details. But I don't think it's technically correct that Sheffield only deal with cancer. What the answer may have been is that for certain procedures they would expect that facility and that expertise to be available locally, and therefore they would only necessarily provide support in the absence, of a colleague. So again, it depends upon it, but I don't think it's technically correct that Sheffield only deals with cancer. What they deal with is more complex cases. They deal with cancer cases, but they will deal with different specialties in different clinical areas. So for instance, Doncaster's orthopaedic department does almost a full range of clinical procedures, but there are some cases that will go to Sheffield to be seen by a Sheffield colleague, and those cases will be orthopaedic cases, not cancer. So it depends upon the operation and the actual specialism that we're talking about at the time.
Okay, so I think if you could provide that written answer, Richard, that would be really useful, rather than having the continued discussion here, if that's okay.
Yeah, I mean, I would need your mum's details to know exactly what procedure we were describing, and then we will be able to fully answer the question.
Thank you for that.
Thank you, Leanne. Do any other health or care colleagues want to comment on any of the questions that Leanne raised? No? Okay, and I think, the answer in terms of, we will see it with the health and wellbeing strategy, and when we talk about minority health, it's absolutely clear the impact that austerity has had on health, social care, wellbeing, not just in Doncaster, but everywhere. But I think our opportunity is to try and do our little bit to try and reverse that and do our best by working together. Is that okay, Leanne, if we get those written?
Yeah, thank you for that, Rachel.
Thank you. Okay, so we'll move. Anybody else, sorry, that's got a question? No, okay. So we will move on to item 5, which declarations of interest. Does anyone have a disclosable pecuniary interest or other interest to declare in relation to the business on today's agenda? If so, please declare it now and complete a declaration form from the Governance Officer, Jonathan. No, okay. On to item 6. So that's minutes of the Health and Wellbeing Board meeting, which was held on the 9th of November. The minutes of the board's last meeting are attached at page 1 of the agenda papers. The board is asked to consider and approve these as a correct record. Can we agree the minutes as a true and accurate record, please? Thank you. Anthony.
Thanks, Chair. Just a quick update, because members will see on page 3 that we, and it was in response to Councillor Smith's question last time, that we had resolved to bring something in January regarding future service provision. That was a long topic and complex topic that we led ourselves onto. I've had a chat, and I think it'd be more helpful to bring that back in March, Chair, because there's a number of conversations that are going on at the moment around future service provision, accessibility and equity for patients, and that will form a big part of our plans for 24-25. So much better place to bring that in March.
Thank you, Anthony. And on that same item was that was point 1 in terms of Health Watch working with Louise to promote information and support about advocacy, because it was we were really clear that we wanted everybody to know about what advocacy support was available. Did that happen?
Yes.
Yes, we did meet and we did do some work together.
It'd be useful just if the board could see what went out, just so they can share it with people as well, because I think advocacy is so important, because people really do struggle. I mean, Leanne mentioned a few sources of support there, but not everybody would know about them. So really important that people know where to go. I think that's the rest, and obviously there's a number of things that are going to be coming back to the March meeting, so I'll provide nice biscuits for the March meeting, because it's going to be a long agenda. Thank you. Okay, so moving on to really important item 7, health and wellbeing strategy, which Claire is going to present. She has actually got a presentation now, which gives us something all to focus on, which is good. And this is about our health and wellbeing strategy is long overdue and requires an update to reflect the significant events and changes that have taken place since we last completed this in 2016. So I think Claire is going to make some proposals and would really welcome everybody's comments when we come on to questions, please. Thanks, Claire.
Thank you, Chair. So we've said at previous meetings that we'd provide regular updates on the progress of the health and wellbeing strategy, and today we'll focus on that work, but also just to say that it links to the work of the ICB and the 5-year forward plan. Ruth sat next to me today, and we've been working together on some of the elements that will inform both plans and strategies. There we go. So background, we know all this around that the health and wellbeing strategy is overdue, and we need to provide an update and provide a rewrite of the health and wellbeing strategy. We've been working together with the ICB and other colleagues that are in the room to collate and analyse all the relevant data, insight and evidence that we've got at the moment, and we've been using that to develop some priorities and delivery plans so far. I'll go through in detail some more information around some of the engagements work that we've done and how we've been gathering resident and community insight. But we've been doing that since around August. So we've been building on the foundations of the Fairness and Wellbeing Commission. There was a lot of work, as we've already described before, that has taken place. And we've been wanting to just build on that and then go and do some more focused, targeted work around what residents are thinking, are saying, and what views they have around health and wellbeing. So that work's been taking place between September and November. And I've been lucky to have Marie, who's helped to gather some of that information into a report around that resident engagement, and that will form part of a technical document that will go under the health and wellbeing strategy. On the 29th of November, we held an informal health and wellbeing session to discuss the Fairness and Wellbeing Commission recommendations and how those that can fit into the Health and Wellbeing Board's role, but also how those recommendations inform the health and wellbeing strategy. And following on from that informal session, we did have a good discussion around what the role of the Health and Wellbeing Board might be going forward in delivering or supporting a health and wellbeing strategy. And we've put a meeting in for the 9th of February to have a bit more of a deep dive into that, and I'll talk a bit more about that in a second. Ruth and Fran Joel from Health Watch have been pulling together a residents writing panel. So not only have we got in all the engagement and insight that we've been collating, but we've also looked at bringing some residents together to see what a plan looks like, what it physically looks like, what a strategy looks like, what residents would like to I suppose receive these plans and strategies that we're writing. So a couple of those sessions have taken place, and we've got some more in the diary as well. We are doing this as true joint with the forward plan for the ICB. So Ruth and I and colleagues have sat and started that writing session, so physically sat in a room trying to look at what elements cross over, what elements will support each other, and what that would look like. And then I did a round of best practice conversations just before Christmas. So I managed to get hold of Barnsley, Calderdale, Bradford and Sheffield just to have a discussion about how does the Health and Wellbeing Board work there, how does that link to their place committees, what do their forward plans look like and what do they look like in terms of their health and wellbeing strategies. Interestingly, Barnsley and Sheffield are looking at revising their health and wellbeing strategy at the moment, and Calderdale are reviewing the way that their health and wellbeing board works at the moment. So I've managed to gather some of that information just to see where there might be some elements of best practice. So one of the things that we have done is a JSNA review. So we've looked at the data. So Laurie Mott has gone through the information that we have at the moment, the data that's held nationally, and some of that is through what we call fingertips from Public Health England or Office of Health Improvement Disparities. As always, a caveat with the data is it's as up to date as it is at this moment in time. So some updates are always being released, and we were waiting and holding on. We were expecting some updates in September, and they've taken a little bit longer nationally. But these are the potential challenges that we've identified. So these are the things where we might be having a trend that's not going the way that we would like it to. It might be where data is significantly higher than our, say, SIPFA neighbours, our regional neighbours or national averages. So at the moment, we've talked about this previously in health and wellbeing boards, is around healthy life expectancy. So we do have challenges around, yes, healthy life expectancy has been falling since 2015-17 data, but Doncaster does now report some of the worst rates for healthy life expectancy, both in males and in females. They are both going the wrong way. The Fairness and Wellbeing Commission talked a lot about inequalities, social disparities, health inequalities, the challenges that different residents experience, and that is very linked and correlates quite highly to the high levels of preventable disease that we have. So the diseases that we have that can be prevented are significantly linked to deprivation, and when we talk about austerity, it links to that as well. We've been looking at information, and at some of the data on child and maternal health is looking quite poor for Doncaster, in particular around children's unhealthy weight, infant mortality, and also children killed or seriously injured on the roads. We know that we have higher rates for smoking, poor diet, drug misuse and alcohol in our adults, and we also have higher levels in activity compared to some of the regional and national averages. And we've been looking at the data that we do hold, and there's lots of different elements of data around mental health, but mental health, suicide and loneliness, again, are an outlier for Doncaster. And then one of the other things that we do have is that musculoskeletal disorders are our fourth highest burden of disease for Doncaster. So that's quite interesting and potentially links to our preventable disease, so links to our obesity levels, our inactivity levels as well. And obviously that has a burden in terms of if you're thinking about sickness, absenteeism and worklessness, musculoskeletal disorders do link into that. So that's some of the headlines. It is literally a snapshot today, and we need to do a big deeper dive, and what we are working on is what I would say is the story behind that data. So they are the headlines. What have we got locally? What do we know locally? And so we're going to just kind of build on that to be able to bring that to the 9th of February's development session. So we've talked about resident voice before, and that we've been building on all of the engagement work that's taken place and all that work that we've done for the Fairness and Wellbeing Commission. So we've been pulling all that information together. There's been a lot of work that colleagues have done across the system, whether or not that's for commission services, for service pathways, whether that's for community engagement around appreciative inquiry. So we've got a lot of information that we've gathered. And we did a synthesis workshop in August with not only health partner communication leads and engagement leads, but also slightly wider than that as well. So some council colleagues and also the voluntary community sector as well. What we've done with that, those themes, is that we've then gone out to do some targeted focus groups as well to build on that, just to test that information that we've had. And if we pull together all of the resident voice that's been done through the previous engagement and some of the targeted work that we've done over those couple of months, this just gives you an idea of some of the either individuals, organisations, statutory organisations that have kind of contributed to that, all that engagement. So there's quite a lot there that we've tried to look at, and we've then done that check about, well, who else have we maybe not heard from? Obviously, it's not just about who we speak to, but how we do that. So again, I believe that we're good in Doncaster about some of the methods that we use around engagement. So we've got significant experience in appreciative inquiry. We've been using citizens panels in different ways. So if you think about some of the work that Get Doncaster Moving have done and their use of citizens panel on a regular basis, we've got our community connectors. We've done, traditional consultations, whether that's around services. We have our staff that do drop-in sessions, and we do this through events. So we've got a significant number of ways that we've done that so that we can try and gather information from residents as much as we can. I have to thank Doncaster and Health Watch Doncaster, who have done the targeted focus groups and have gone back out and had some more conversations based on the themes that we've talked about. And those themes probably won't be a big surprise, but as you can imagine, access to services has come out. So we know time and time again that people will talk about that access to services. But some of those themes that link into that access to services, that might be around transport and location. It might be about navigating services and appointment systems. We've also had a theme around mental health, so not just around severe mental health, but the understanding and awareness of residents around their friends, their families, their neighbours around low-level mental health and what is good around how to keep good mental health as well. So there's been that come through as a theme. We've called it the wider determinants of health, and we probably wouldn't use that in when we talk to residents about health and the wider determinants, but those things that do impact on our life, and again, going back to the Fairness and Wellbeing Commission, that wider kind of contribution to people's well-being does link to public transport, does link to where we live and the environment that we live in, housing and accommodation, and we know that housing is really key about people having good health, employment training skills, health literacy. Do people understand how to access services? Do they understand the terminologies that we use? Cost of living crisis, and we've already heard today about austerity and that being brought up about how that impacts on health and wellbeing as well. And how community groups and voluntary sector and activities can help with our health. And then community safety, which was a big theme of the Fairness and Wellbeing Commission, about how people feel safe in their neighbourhoods. And then an element around health inequalities, and this is probably being described around certain different residents have different challenges, and that, around that disparities and how access to services or access to support or access to good living is different across our communities. So that's some of the themes around resident voice. And as I said, we've gone back and we've done some targeted work, just reaffirming some of those themes. Ruth's pulled together this brilliant diagram, which has deep dived a little bit more into access and equity in access, how that links into the Fairness and Wellbeing Commission in the top right-hand corner, some of the themes and what have been emerging specifically around access and equity, and we've talked about them already, but in there it also is around translation and language, around digital inclusion as well. We've then linked that to the Joint Strategic Needs Assessment and some of those headline data that's coming through, some of those headline challenges. And then an extra element that Ruth's been working on in terms of the ICB forward plan is around workforce voice as well. So that's particularly important around access and equity, and some of those themes that are coming through about co-location that we've talked about, community first type of access to services, but also using kinder language, being able to have the ability to work with third sector organisations. So it just demonstrates what we've gathered, what we've pulled together, and how that's linking together. So we've gathered all of this information, all of this data, and we're just trying to look at what potentially are the priorities for the Health and Wellbeing Board and for the Health and Wellbeing Strategy. So we're linking into that vision at the top, which is in the Doncaster Delivering Together Borough Strategy. So that is a compassionate borough where collectively everyone is supported to add life to years and years to life. So it'll be interesting to see if we still feel that is a vision that's still relevant today. And, it does follow some of our compassionate approach that we've been taking. Linking that through to the data around life expectancy and healthy life expectancy and that resident insight, and also that work on the themes that have come through from the Fairness and Wellbeing Commission. I've proposed 6 priorities at the moment, so what we've been working on. These link quite closely to Marmot principles that look at addressing health inequalities. I'll read them out because I don't know about you, but my varifocals don't maybe not read that. So we've got the best start in life in a child-friendly city. So that works towards some of that child and maternal health indicators. Significant amount of work taking place around that, and also links to that aspirations work that we've been working on in Doncaster. Good jobs and good employers, and the role of where there's a bit of a circle, isn't it, in terms of we need good health to be able to have a good economy, but also that good employment also contributes to good health. So the work that's been taking place on that. In terms of linking into preventable disease and addressing preventable disease and that challenge, we need thriving health through cultural and physical activities, and the early prevention that being involved in and having access to cultural and physical activities has on preventable disease, but also about protecting residents from harmful products. And that links to some of the commercial determinants of health approach that we're looking where we're trying to address residents being, having access to alcohol, smoking, tobacco, and some of our work around tobacco-free environments. We've got a priority there around safe and healthy homes and places, which can obviously fill quite a lot of priorities, but around that healthy homes and that our places and environment and our neighbourhoods are places where we can live healthy and good lives. And then the last priority there is around compassionate local support to help people to help themselves. And then underneath there's some principles, looking again back at the Fairness and Wellbeing Commission, some of those principles that have come out, so around intersectionality, around people have different varying challenges that they need to deal with on a day-to-day basis, around having an evidence-informed approach for the Health and Wellbeing Board. And we're very lucky to have the HDRC, which Susan and Caris will talk about in a second, but around our work being evidence-informed. That obviously it's community-centred and follows our community-centred approaches that we've been taking over the last few years, that we still continue with our health and all policy approach, and we've been really successful to do that in Doncaster, and that obviously we work in collaboration, and that's really important that we've got this unique opportunity to link the 5-year forward plan for the ICB and the health and wellbeing strategy at the same time together. So that's just some of the proposals that we have that I'm mooting today and that we need to look and to have a further deep dive in. Obviously, we'll start to work on the structure, but just to talk very quickly about what that might look like. So about having that main document that's short and succinct and gets to the point, but that we have a plan on a page. We may then look at an outcomes framework depending on what the role of the Health and Wellbeing Board is in addressing some of those priorities. And obviously then we'll start to look at the most appropriate resident versions as well. So what do they look like? And the resident panel, writing panel is really key for that. And then we'll have a lot of technical documents underneath that not will be only useful for the health and wellbeing strategy and the forward plan, but for future strategy and policy documents around the health challenges in Doncaster. So these are the next steps so far. So they're on the 15th of January, which is Monday. There is conversations taking place with the chief executives around place and looking at those priorities for their health and care services and sector, to look at that and how does that feed into the health and wellbeing strategy and the ICB forward plan. I've got a meeting with the LGA, their local government association, on the 18th of January to see what support offer they can give to a health and wellbeing board around how we want to take forward our priorities and how we want to work going forward. So I'll be updating the board on what that offer is, and hopefully that we'll be able to get access to that support, and maybe almost like a peer review, I suppose, going forward. If not, we'll still be continuing with that work anyway. Talked about gathering the story behind the data, and we're just starting to do that at the moment. We've got further resident writing panels penciled in. And then on the 9th of February is that development session for the Health and Wellbeing Board. So this is still to be determined, so I'll be happy to take any thoughts and considerations about what that development session needs to do. But at the moment, it's thinking about, we want to really agree those priorities. We really want to have a conversation about what areas do we want the Health and Wellbeing Board to focus on, or is there specific actions that the Health and Wellbeing Board wants to sponsor, for example. And then start that conversation about the role of the Health and Wellbeing Board and how what is the ask that we might have of the LGA for some support to do that over the next 12 months. And then we'll start looking at that socialisation strategy. So to start to talk about, once we've got those priorities confirmed, we can start to talk about those priorities to other areas before we finalise that strategy. And then obviously we'll start to look at that final report design and approval process. I'll stop talking there. very whistle-stop tour, quite quick, to just give you a snapshot and a flavour of what we've been doing over the last couple of months.
Thank you very much, Claire. Very comprehensive. And no doubt people are going to have comments. Starting with Anthony.
Yeah, thanks, Claire. That's a really good update. And just as what I would comment on is that I've got a lot more confidence that these plans are being put together, for want of a better term. I think in the past we've maybe had a bit of a health and wellbeing strategy and a place plan that didn't necessarily align. I'm more confident that we will absolutely get there, and I can see that those conversations are being had together. In terms of support from the LGA, why wouldn't we if that is beneficial? So I think there's something about digging into that and how that can support with us, because I think we should have that sense check if that's there for us. The final thing I'll say is that I'm confident that the plans will be put together from the evidence, including the Fairness and Wellbeing Commission, from what our residents are telling us, and that's been really comprehensive, so well done on that. But also, it would be amiss for me not to mention that there will be, conservatively speaking, around a £40 million gap in healthcare in Doncaster going into next year. So the plans that we put together have to be around addressing that, and that can be done through transformation and efficiency and integration. But if they're not concentrating on that, then we need to have a sense check for it.
Thanks, Anthony. I've got Sarah and then Glynis.
Thank you so much for a really thorough presentation, and there's some sobering data points in there about what it's like to live in Doncaster, including like elements of one thing that stood out for me was children getting killed or seriously injured on roads. I didn't know, is that children getting run over on the roads, or is it injured in cars as well? Well, I'll let you see.
So, I mean, I can come back to you and do a bit more detail. We are doing a dig deep into that, and that story behind the data is some of the things that we're looking at. What I understand at the moment is there was a change in how KSIs were measured or reported by the police. So we have seen an uptick because of that. But what we are seeing is not as many children killed, but definitely injured. And we are, when we've looked at the data quite quickly this week, we're definitely much higher than the England average and our SIPFA neighbours. So we want to do a deep dive, and I want to understand where those accidents are taking place as well. So yeah, so that story, dig deep, and it is sobering. I agree.
Thank you for that. Yeah, and I'd love more information on that generally. But in the integrated care place integrated care partnership, there's so many, isn't there? Strategy, there is a whole thing there that is about, one of the things is a priority on looking at and dealing with young people being injured on our roads, because South Yorkshire generally is in the top 10. And, you know, there is some shortfall in funding because of cuts, but I believe that this is where we're supposed to be pulling on to that partnership and really connecting these dots. So there is some really good overlay with that partnership strategy, and I'd be really interested in how we're going to be using that to our best ability for our Doncaster residents and to make things happen. So I don't know if that's if there's anybody in the room that is connecting those dots for us going forward.
Anybody want to answer that question?
So in terms of the ICP operational strategy, there are some bold ambitions in there, and I have been liaising with the ICP on the link between us. And in terms of addressing road safety, we do work in public health on that. So as you'll know, there's quite a bit of work that we've been doing on that, linking to our road safety team. Obviously, financial pressures are a challenge, but it would be good to try and work out what at a South Yorkshire level is taking place around that. So we can talk about that, and we can have a look into that. But definitely, public health are working with our road safety team locally on that.
Yeah, some fantastic work locally, but I think we need to get that investment if it's in the strategy to pull down, especially given that we're one of the highest in the country.
Thanks, Sarah. And I suppose the question, just following on from that, and I'll bring other people in, is if something is in the South Yorkshire ICP strategy, how do we benefit as Doncaster? Like, is there funding available? Anthony's smiling, but I think the idea was when we've discussed ICP that there would be some advantage in having that. That's why there's 5 of us from this group that are on it. But today, and it might be because I'm not in the detail, I haven't seen anything that's such as this that's meant that Doncaster actually benefits.
To come back on that, and I think, Chair, that does need more visibility, because that is very much the intention that is put there. I haven't been to the last ICP meetings, Rachel. I don't know if you have, so it probably is worth bringing some of that back here to another meeting, isn't it?
I'm going to take a liberty, Rachel. You're going to collect a drink, just to add to that. So, from a South Yorkshire mayoral combined authority footprint, there has been in operation for around the last 6 months a health equity advisory panel, for which the directors of public health across the 4 local authority areas have been members of, and for which Claire has been linked into as well. So, as well as us at place level, each of the local authorities be in the process of developing, refreshing, renewing joint health and wellbeing strategies. There will be a South Yorkshire-wide report as well. It looks like it'll be 2 reports, one on recommendations and one on enablers. So that's in development as well. We've ensured that we've had a Doncaster voice in and through that as well, and that each of our different products will be saying similar or the same things, obviously with focus on Doncaster where that's required. So those links are there. I think I must say it's been a very busy year, I think, for new groups with health partners as well, and being able to support and to resource those, including health and wellbeing board meetings. But we have, where we've been able to, made those links and ensured crossovers, whether it's been linking Claire, and she's been working on this too.
Thanks, Rachel. I think it's down to the members of the group to then have those more detailed, to use the ICP meetings to have those discussions, isn't it? And if we could note that, that's something the members can pick up. So, not wishing to miss people, so I've got Glynis, then Phil Holmes, then Lee, and then Nigel.
Thank you for that. Thank you for that report. That was really comprehensive. And I'm really pleased about the Marmot principles, because that's an individual who I think is absolutely amazing, and I have met him. We talk about resident engagement an awful lot, and we've talked about targeted services as well. So my question really is, are we, when we're asking those questions, bearing in mind the huge disparity across Doncaster for life expectancy, are we asking those questions in our most deprived areas in Doncaster? Because there would be little point in asking them in some of our areas where there's a huge difference between life expectancies in Doncaster. And do we have figures around resident engagement?
Because a lot of the work that we've done is based on the synthesis of all the engagement that's been taking place from different colleagues and partners across the system, I haven't got an exact number to say we have used this many, we've spoken to this many residents. I would say when we did the synthesis engagement session in August, we talked about how we'd done some of this. So say, for example, if it was DRI, for example, and their engagement, how they'd done that with patients, similarly with Health Watch, with Well Doncaster. So we just wanted to make sure that we are speaking to residents who are from across Doncaster, not just people who maybe have a tendency to want to fill a form out, for example. I'm confident that we've spoken to people that are from the most deprived communities, and we have done a lot more further targeted work. So we have used our Well Doncaster team to make sure that we're in their areas, and they're all areas that are from the most deprived communities. And Health Watch have also gone out and done some targeted work. So we've tried the best we can to make sure that we've represented residents from across the board in terms of our engagement. And hence why I put the whole big list up. So I didn't do geography, which is an interesting one, Glenn, so I might do that. But yes, so geography probably would be a good one for us to add onto that. But yes, we definitely have done that. And the Fairness Commission obviously had that huge focus on social disparities.
So can I ask Health Watch, have you got any figures for engagement?
Hi. Not off the top of my head, no. I mean, we know how many people we've spoken to and we know that. One of the things that we've also concentrated on is rather than just going, oh, look, let's get as many people as we possibly can, we've made sure that we've spoken to the people who we need to hear. And we've made sure that the questions that we've asked and the way that we've spoken to them has been useful information and deep information as well, rather than just going, let's talk to 100 people. We've made sure that the people that we've spoken to are the voices that we need to hear. So I know that we can put some figures together for you, if need be. We can do that. So the figures are there.
Thank you. Is that okay, Glynis?
Yes, as long as we see those figures.
Yeah, lovely. And I've got then Phil.
Yeah, thanks. Just on the ICP point, it might be an opportunity for us in the February session just to rethink our engagement with the ICP, because the membership of 5 you referred to, there's probably been a few changes in that group. And if the ICB were going to be defensive about the ICP, they would say it was a partnership between the ICB and local authorities, so it's about what we all put in, so we can maybe think about whether there's anything we can do around our input from a Doncaster Place perspective. I was going to say it was a really good presentation. It really was good, because it was good to see the way Claire sat out the different stages. And I thought it was quite powerful to see the kind of access list of concerns, including adult social care. I think it said social care, but it may have meant children's as well, who knows, but under healthcare, so there you go, maybe that's the future. But it was good to see that list of access issues on the left-hand side. And then it was good to see a list of more preventative, holistic issues on the right-hand side. That might help us think next time about what the Health and Wellbeing Board needs to directly focus on and what it needs to charge other bodies with doing. Because I think there's probably something in access around poor access probably drives poor use of resources, which probably drives overspends. So there's things to think about in an access space. And then there's the wider work to think of. So I think the way it was set out was really helpful. I'd be a bit worried that when we got to then we talked about the themes of the health and wellbeing strategy, I'd be a bit worried that that was lost when we got to the themes at the bottom of that big slide that Claire presented. But I still think there's something worth revisiting there. And when we have our session in February, maybe think about the statutory role of the Health and Wellbeing Board, so we don't lose sight of what we're required to do, and then we use that as an umbrella to think about what we want to do underneath that.
Thank you. I've got Lee, Nidge, and then Ray.
Thank you, Chair. Yeah, the report was great. Strategy is great. From a children's point of view, it's great to see early years on there. There's lots on, and that's fine, and we're on with that. A couple of worrying things. So the road traffic one, really worrying, and just sat here makes me think that we kind of half know about it, but we don't know the detail. And thinking around our connectivity to the system around children and people, there's a conversation for us to have, Claire, outside of that about, well, actually, what does that mean in terms of education via our schools, via other settings, school crossing patrol sites, for example. I mean, we've got more school crossing patrol staff than we've ever had, but actually, are they in the right place? And so there's some further work for us to do, because that is really quite worrying. And then the only other thing I wanted to flag was around, it's good to see children's mental health in there. So we do have a robust mental health strategy. We still see far too many children in acute settings with episodic periods of crisis around children's mental health. So I just wanted to flag to this board that the Children and Families Exec Board have agreed, as of last week, that we're going to really dig into the granular detail around the acute end around children's mental health. So we can kind of we're going to own that, and we can provide updates to this board if you want. So I just wanted to flag that.
Thank you, Lee. Nigel?
Yeah, thanks very much, Chair. Yeah, just to say thank you very much for the report. It looks really, really comprehensive, and I endorse everything that's on it. I mean, I particularly like those areas and the pyramid that covered some of those areas, and also the residents and the residents' concerns, particularly around, and what shone through for me on that, obviously, is all our access to services in all its forms and gamuts. I mean, I suppose what concerns me above all with this is that I mean, there's been a fair bit of talk around how we engage with residents and what residents are feeling, and clearly, you know, that's coming through on there, you know, and you can see that there's some themes coming through as well. And the question got asked earlier on today, certainly by one of my colleagues, in terms of sort of like the effects of governmental cuts and austerity on services, and also people's longevity and people's lives and people's health. And I think, you know, we got a pretty frank sort of like, response from Richard Parker, obviously from the NHS's position that the pandemic has obviously had, you know, quite a lot to play with it, but continued austerity and cuts are obviously having a massive sort of like toll on our communities. What concerns me is that any right-minded government, looking at the stats that we present in Doncaster, particularly around our most deprived communities, and certainly in terms of people leading healthy lives and longevity, any government looking at those stats would think, actually, we need to think about this differently. We need to actually start putting some money into this and into services. But what we've got, according to Anthony, is we've got a funding gap. And we've got a funding gap of, did you say 40 million? So on top of the austerity, on top of the cuts, 14 years of these, what we've now got is we've got presented with an NHS, because I feel sorry for NHS in fairness, NHS services are saying actually there's a funding gap there of 40 million. Let's call it what it is. It's not a funding gap, is it? It's a cut. That's effectively what it is. It's a cut in services of 40 million that's going to directly affect the people of Doncaster. It's as simple as that, really. And then when you place that against some of the new initiatives that has obviously come down from government. And I mean, I struggle with it, I do, and I mean, I try and keep on board with it, I struggle with it, where, you know, government said you need to form an ICP. And obviously I sit on the ICP, and Rachel's just disclosed that there's this equity board that she sits on with other directors of public health, and there's so many committees that you lose track of them. And I don't see the connectivity, and I don't see, in fairness, visually what's getting better for Doncaster or the people of Doncaster from our most deprived communities. And at this moment in time, I've got to say that I have concerns with those bodies and with those committees in terms of getting the best deal for the people of Doncaster in our most deprived communities that are really struggling after the pandemic, but more than anything else after 14 years of Tory austerity.
Thanks very much. I think you hit the nail on the head when you said right-minded government, but we'll quickly go over that because that obviously would result in action being taken. Rachel, did you want to come in next?
I did. Hopefully this speaks to some of the points raised by previous persons that have spoken, perhaps not quite to Nidges, but just around the development of the joint health and wellbeing strategy. I'm really pleased with the work that's happened so far and everything that's gone into it. We've had health and wellbeing boards for just over 10 years now, and different places will have had strategies. Either they'll be on their second, third, probably fourth strategy, probably similar for us. We've learned a lot, places have learned a lot about how we develop health and wellbeing strategies, and also how we deliver them. So that's the other important element to it. What others have spoken about as well as some of those key areas coming out around access, certainly, and also prevention, and also what Rupert would describe as the other 80%, so those causes of the causes, and that's what came out of our Fairness and Wellbeing Commission process as well. We've got a lot in the mix there, and would really like to use the development session that's coming up in February to look at the next steps from a couple of different angles. So one is content of the joint health and wellbeing strategy, given all the work that's been done and everything we've heard so far. And then the other part will be how we deliver. So what's the process and mechanism and role for delivery? Have we got the right persons at the Health and Wellbeing Board table, and have we got the right process that we come together, because the strategy will talk to what we see and what we tackle through this board and the work that happens around this board as well. So yes, thank you, Claire, and others that have been part of all of the work, and ICB colleagues as well, to get us to this stage. And the crunch bit will come, I think, at that February session where we get to our content, considering all of the challenges that we've got as well that have been described today, but also those methods of how we deliver the strategy and the actions around it. I did also just want to note that I think a real positive for Doncaster is the borough strategy. So the borough strategy as is to be a public health focused document. So in some ways we've got a really good background for us there, and how do we look at other strategies that we've got, including health and wellbeing strategy, as being complementary and enhancing parts of that too.
Thank you very much. Unless anybody else wants, I'll just sum up. So there's a specific action there in terms of understanding the geography and numbers, and that'll be Claire and Health Watch that will send that to us, which will be really useful. I think everybody's really pleased with the approach, and I think we've got to the point of having a resident writing panel is really taking that engagement to the next level, which is brilliant to see. Picking up what Rachel said, it really concerns me that we've got on there, you know, the colleagues already mentioned it in terms of the accidents for children, and also safety, that came out really strongly, and also public transport. On the latter, I think we often take the view, well, it's South Yorkshire Mayoral Combined Authority's responsibility, but I would like them at the table about how we address this, because it clearly came out. If people rely on public transport at the moment in Doncaster, it's not good enough. And what can we do as a Health and Wellbeing Board to influence how Simca, you know, give out their electric buses or what other services they provide for us in Doncaster? Really as well, I think, you know, I'm quite happy to write to the police. Safety came out, it's one of the priorities that you've said, safety in the home, safety in the community. And I think if any of us have been affected or work in the field of where people don't feel safe, how that then impacts on healthy life expectancy, on well-being is huge. So I really do think we need to get the police to that session. But also I'm going to make sure that, well, try and get our Director of Place there as well, because it's so important that when we're talking about road safety, that we have the right people actually in the room, because I think perhaps politically we need to look at where we direct our resources. And for me, if we get this health and wellbeing strategy right, then it really will direct the resources on where we put them. Just another question I wanted to pick up on, and you know it's my hobby horse, in terms of, you said about healthy life expectancy for men and women. I wouldn't want to lose the issue that we've heard before, that women's life expectancy is the third worst in the country. I'm not saying that I don't want to ignore what's happening to men, but for me that's something really specific that we need to be looking at about what's happening in Doncaster and why that is so poor, given the determinants that shouldn't have us that low. So I would really hate that that was lost. So there's a couple of actions there that we need to take to make sure the 9th of Feb session is really important. But everybody seems very happy with the proposals. I think, you know, what we would ask from the writers panel is that they are encouraged to make sure that what's produced is something that is really easy to read, but really easy to measure, that we're making a difference. And I think that's something that we don't always achieve. So something really measurable that in a year's time when we're sat here, we can actually see some numbers, we can see some difference about what's happening. Have I missed anything in terms of the summing up? I think I've hopefully captured everything. Okay, thank you very much, Claire, and pass on our thanks to the team. And in terms of, I noticed on the next steps, so are we looking at March having the health and wellbeing strategy presented? Not as though we haven't got a big enough agenda, but is that the plan?
So we'll see how we progress on the 9th of February at the development session, and yeah, we will aim to get it written as soon as we can. As long as we get those priorities kind of down on paper, and we're working out what the areas of focus are for the Health and Wellbeing Board. I think we're making good progress.
Okay, thank you very much. So we're now going to move on to item 8, which is health determinants research collaboration update. And we've got Susan and Caris here, I believe, who are going to provide a summary of the work done to date, the principles and approaches being taken, and an overview of next steps. Thank you.
Fantastic. Thank you. Sorry to be wandering around during your introduction. I was just trying to grab hold of the clicker and get some instructions. So hello, everybody. I know I introduced myself at the beginning, but I'm Susan Hampshire. I'm part of the public health team at the City of Doncaster Council, and I've got the great privilege of being the director of our health determinants research collaboration. Last time I was here talking about this, it was very much a bid that I was seeking support from, and I remember sort of saying, you know, this is a real opportunity, but we may not get it, but it's worth that having a go. And if not Doncaster, you know, why not Doncaster? And I think you said at the time, Rachel, why not Doncaster? And we've been really fortunate in that we've been successful, and we're a year in to the work. So it feels really positive to be coming back to talk a little bit about what we've done so far. So I'll just see if I've followed the instructions properly. Marvellous. We'll come back to the recommendations. So obviously in March 2022, we reported that we'd submitted this stage 2 application, and we've been successful. We received funding of just over £5 million because we've had a slight inflation uplift to run from 2022 to 2027. And the idea is really to set up a health determinants research collaboration. I'll talk a little bit more about what health determinants research collaborations are. I'm going to abbreviate that to HDRC because it's quite a mouthful. But what I'm not wanting to do is go through some of the detail about why Doncaster and why inequalities, the wider determinants of health, all of those things are really important in this agenda, because we've had an awful lot of that background from Claire in the work that she was talking about from the Health and Wellbeing Board. So we've done quite a lot of really successful work over the last year, and we're viewed nationally as being ahead of the game on many levels because we have managed to get our team in place. I'm going to talk about that a little bit more. We've managed to set up our governance arrangements. We've got an advisory board actually chaired by David Pye from the LGA and others across the United Kingdom, also including colleagues from Canada are part of our advisory board. And we've done our first annual conference back in September 2023, where we were in the CAS building. We had over 100. Am I exaggerating? Just under 100. Thank you. Caris is my guide. She kicks me if I agree to some things or if I exaggerate slightly. But what we've managed to do in that first conference, and the pictures at the beginning of the presentation illustrate some of the people and some of the events that we did as part of that conference. But we managed to get nearly 100 people who were officers of the council, who were interested in getting involved in research. And that's the essence of what HDRCs are about. They're not necessarily about doing research, although we have done some over this period of time, but they're about actually building the capacity and capability within local government to undertake research, to get us to the same level of undertaking research that happens in the NHS. And we're really lucky in Doncaster because we've got some real trailblazing research going on at DBTH and at R-Dash. So we've got something to really emulate there. I'll move on to the next slide. So a little bit of background about what HDRCs are. So they're funded via the National Institute for Health and Care Research. And in particular, they're funded through the public health stream of that particular work. And they reflect a recognition on the part of the leadership within the NIHR that previous public health research and investment, although really important and worthwhile, had tended to focus on health protection or very disease-specific research. And it hadn't really focused on tackling or understanding the wider determinants of health, because although obviously in Claire's presentation, the wider determinants of health came out as something really important from both a residents' point of view, and that we can make some really clear labels about how these things impact us and the causes of causes. What we don't necessarily know is how to address those and how to address those locally, and research can help. So the NIHR felt it was important to do research in this particular area, and then they looked at local government and realised that there was absolutely no capacity at all in local government to be able to do it. They recognised that there was capability, that there was a real interest in doing research, that there were colleagues who were doing research-like activities, they were doing evaluations, they were doing service reviews, but we didn't have the underlying infrastructure to be able to do research. So they did this call that I've obviously talked about, and in round one, they actually put in place, in the end, 13 HDRCs. From a Yorkshire and Humber point of view, there's only one more in this first round. There's one in Bradford, and then there's us. So, you know, we're kind of punching above our weight from a Doncaster point of view. They've just announced funding for round 2, and there are another 11 HDRCs, each with a rough investment of £5 million, and 6 who are in a development stage. So by January 2025, there will be 30 HDRCs across the country, which is really positive and a really significant amount of investment to undertake research in local government. We're now fortunate to have 4 HDRCs in Yorkshire and Humber, so Wakefield, North Yorkshire, Bradford and Doncaster. And as an HDRC team in Doncaster, we supported both the North Yorkshire bid and the Wakefield bid through the stage 2 funding and supported their interview process. So we're really pleased that they've been successful, and we hope to collaborate with them over time, because actually the really important word in HDRC is collaboration. And our HDRC is initially a collaboration between City of Doncaster Council, University of Sheffield and Sheffield Hallam University. But over the course of the last year, we've recognised that actually not having a specific university in Doncaster is a little bit of an advantage from this point of view, because it gives us an opportunity to work with universities the length and breadth of this country. And although obviously we want to work closely with our closest universities that are part of this partnership, we want to extend that to other places across the UK. I suppose one thing to say is that there'll be 30 by 2025, and we hope that there might be a third round, and there's an awful lot of interest. So one of the things that we would want to do will be to really support the other authorities in South Yorkshire to go for it if there is an opportunity. I'm not expecting you to read this at all because it's a tiny diagram, but you have got it in your packs. But what I did want to use this particular slide to describe is the amount of capacity this actually brings us as an organisation. We've got nearly 18 people involved in this project, some full-time, some not full-time. We've got a number of staff that were employed by City of Doncaster Council, a couple of them here today. So Natasha is our Public Health and Community Engagement Officer and lead, and Caris is our project manager. But one of the things that's really exciting about these posts, because they've got some substantial opportunity to really either develop a career from a research point of view or a career from a research management point of view. And these are good quality jobs, and we'll be able to attract more jobs in this sort of knowledge economy bit. So on one level, it feels quite difficult to be having a conversation about we've got £5 million worth of investment to do X when Anthony's talking about a 40 million, was it million, not billion? Million. When Anthony's talking about a £40 million deficit. But I suppose there's something about infrastructure and investment that can actually lead to us developing our knowledge economies and can lead to more partnership working and more investment in Doncaster. And there's always been a sort of a link between research, health and wealth, and research investment in a place is good in and of itself. So as I say, we've got a number of staff employed by the council. We've also got a team of 8 embedded researchers. Some of these are not full-time, so we've got the 2 profs who supported the Fairness and Wellbeing Commission, Andrew Booth and Liddy Goyder. We pay for some of their time, and obviously it was a really useful use of their time to be part of the Fairness and Wellbeing Commission. But we've got 6 people who are employed full-time. They may be appointed to either Sheffield Hallam or the University of Sheffield, but they're working on Doncaster work. And this actual capacity to be able to do things really does make a difference. And then we've got lots of people that are associated with this. So we've had the opportunity, and Caris is going to talk more about applying for programme grants and funding bids, but we've been able to put council officers as co-applicants, so that buys out some of their time to work on research projects, and we've been able to put members as co-applicants on various research bids as well. So if they're successful, that will really help build the capacity for doing more research in Doncaster. So this is my kind of summary slide that says what the HDRC is all about. I think one of the things that's really exciting about working in this area is that we have got 5 years. Nobody else has tried to do this, and we've got all of these experiments happening all over the country. So every day, it really is a school day for us. We're kind of learning how to navigate systems, how to make things happen. But our overall vision, the kind of the prize for us, is that we want to really focus on growing capacity to both do research, but also to use research within our decision making. So that links into that idea of the Health and Wellbeing Board strategy being evidence informed. We want to be able to create the capacity for us to be more evidence savvy, to be able to use evidence within our decision making processes, with the view that that will help better outcomes. So we've got a couple of work streams. One's around knowledge mobilisation. There's an awful lot of knowledge out there, and there's an opportunity to work out how we can skill people up to access this knowledge and to mobilise it and to use it in appropriate parts of the decision-making processes. And then our second work stream is really about building the capability, the capacity, and to motivate people to get involved. And so far, there's been quite a buzz and people have been interested in getting involved, but we want to be able to get into like an octopus, get into every bit of the council, spreading our tentacles through the area. So there's lots of work to do in that particular area. And then we've got some enabling work packages. I'm going to come on and talk a little more about public involvement and community engagement. We're really interested in data use and linkage for research purposes. We're working in collaboration with both DBTH and RDash on the Born and Bred in Doncaster project. Born and Bred is a birth cohort study. I've talked about it at previous health and wellbeing boards. There are a number of these across the country, but ours is a little different in Doncaster, in that the engine for data and data linkage is held at the council rather than in the NHS. So we've got a really interesting data sharing agreement between the organisations, and that allows us to look at the data and think about what it's really like to grow up in Doncaster, and where there might be opportunities to undertake research, or where there might be opportunities to intervene and then provide some support to evaluate that intervention. So it's a really exciting model for us. And then the final thing, the final enabling work package, is that we don't want this to fall off a cliff in 2027 rather. We want to be in a position where we're able to continue this work, and so collaborating, finding programme grants, but also undertaking research that's of real value to us locally, and working out how to implement the findings are really important for us. This is all underpinned by our TIDES principles, which we've rehearsed previously at the Health and Wellbeing Board, and we rehearsed all the way through developing the bid. But we were really keen that any work we do is theory informed, And the idea of that is that we know there's some evidence and some theories already in the literature about how you motivate people to get involved in research. So rather than just saying, oh, let's just shout and say, come and get involved in research, we're using theory-based approaches and we're testing them and refining them within local government, because many of these come from the NHS. We're really keen to ensure, and this is a core public health value that comes from Rupert's work, really, this idea of learning by doing. Caris has got numerous examples when she talks through the work that we're doing. We're already getting on with work and we're learning as we're going along. And we're really keen as well to share that both to colleagues in other local authorities to help them in their research journey, but also to share this nationally in terms of the work that we're doing. This third one is really, really important to us, and we're not there yet. This is something that we'll have to strive to work on over the next 5 years and beyond. But we're really conscious in the world of research that it's sometimes easy to default to the academic or to default to the authoritative or the seemingly authoritative, powerful voice. And what we want to do is ensure that we're not privileging some voices or ideas above others. So ideas that are coming from officers, from members of the public, and are just as important as ideas that might be coming from academics. And then thinking about the ways of how do we go about finding out don't necessarily have to come just from the academics. So we're keen to get more equity in there. And then finally, as I've mentioned, I want to be able to retire but leave this as a substantial legacy for Doncaster. So sustainability is really, really important. So I tend to talk when I'm out and about that we've just got this set of building blocks. So this is effectively a more user-friendly slide than the previous one that summarises the whole thing, because we've got some puzzles to solve. We've got to work out how we get what we know from research into our decision-making process. We've got some ideas around that, some from theory and some from the experience that we've had with, for example, the Fairness and Wellbeing Commission. We've got a puzzle about how do we really motivate people and organisations to get involved, particularly at a time where they're trying to tackle a £40 million deficit or they've got other things to do. So we're looking at some of the theories and ideas about how you might do that. We've a puzzle about how we really use and link data for research purposes and not just for improvement purposes. We want to really think about how we properly involve staff, local people, partners, voluntary sector. One of the embedded researchers has been doing some work to support some of the work that James has been doing in the Citizens Advice Bureau, and so we're keen to do more of that work. We've got this overriding question about what should we research. There are some things that fall out naturally that make sense for us to research, but we want there to be some consensus, and we want to keep going this learning by doing. So, for example, we've given people opportunities. So Marie's doing some work as a registrar within the HDRC, so that kind of helps develop further research skills. We've got PhD students attached. We've got people from within the council reaching out and saying, this looks really interesting, could I come and spend a bit of time with you? So we want to not only learn and do by ourselves, but we want to encourage other people to do that. And then finally, before I hand you over to Caris, public involvement and community engagement. So usually when you write an NIHR bid, you don't talk about public involvement and community engagement. You talk about something called PPI, which is patient and public involvement. Of course, we don't really have any patients. I know we do as a system, but we don't from a local authority point of view. And we were really keen to broaden that term. And we were also really keen to do something a little bit different in that often PPI responses are, well, we'll have a group. And they're not about really collecting and working with people and developing trusted relationships. And that's what we're trying to do in Doncaster. So there's some examples of some of the work, but the most I suppose the most exciting and important bits for it is that we've got some real leadership from Natasha in this agenda, and we've got some money, we've got some investment. We've, as part of our £5 million, we've got nearly 600,000 over the 5 years that's around public involvement and community engagement. Can be used to put on events, it can be used to pay for people's time from a consultation point of view, which leads to one of those, but how do we do that? We didn't necessarily have a reimbursement policy from a research point of view, so we're developing one as a council, and we're learning all the different stages we need to go through to be able to do that. Because when you talk to members of the public about involvement in research, one of the things that people find really frustrating is that they have to wait ages to get expenses back, that meetings are not necessarily convenient and all of those things, and we're trying to tackle those within our reimbursement policy. We're also, because as I mentioned earlier, we're really blessed with the relationships we've got at place, so we're working to think about how do we do public involvement and community engagement at place in partnership with DBTH and with RDASH, and so there's some real opportunity there to learn together and to help people who are involved in research understand the importance of public involvement, not as a nice thing to have, but as a fundamental part of the research process. We're in the position at the moment where we're developing our approach to research priorities, and we want to work out how we properly get public involvement in that process, and that's one of the reasons why we've got the budget to be able to do that. And then the last thing I'll just sort of pick out is that as part of Born and Bred in Doncaster, we had the opportunity through the NIHR to utilise their race equality framework, and we've done some self-assessment work around that that's really led to some, I'm sure, I'm not trying to suggest you have to come in, Natasha, don't worry, but we've managed to do some really interesting work in that area, and as a result we're continuing, we've got an action plan and we're continuing to do more, which has made us really think about the importance of having an anti-racist lens on some of the, oh well, not on some, on the work that we're doing from a research point of view. So an ambition for us, but we want to, I suppose, have the opportunity to come back and talk in more detail about some of this public involvement work with the Health and Wellbeing Board. And ultimately, all of this is about getting some ongoing consensus about the type of work that we are engaged in. I will stop talking because I'm conscious I've talked at length and hand over to my colleague.
Thank you.
It's a couple of times, yeah.
Okay. I didn't get the instructions, as you can
Sorry.
see. So I know this slide is a bit busy and it will be hard to read, but this is to just demonstrate a bit of a snapshot of the level of work that we've done so far. So we've currently got 27 live projects. Now, some of those are what we call lifetime projects, so those sort of core work packages of the HDRC. And we've sort of like completed 4 of those so far. These projects have emerged from a range of different areas. So some of those have come from being identified through practice, so where officers or practitioners have identified sort of a gap or something that they really want to dig into a little bit more. Or some have come through the delivery plan and spotting opportunities, and we've linked these to the corporate priorities as well. As we develop more of that prioritisation work, that'll start to feed in. So just a little bit of context into some of these examples. So we've just completed actually one project around representation into drug and alcohol services. So our public health team identified there was a bit of a trend in some people re-entering services where they'd previously successfully completed treatment, wanted to understand this better and sort of know how they can improve that sort of service provision. So they approached the HDRC for a bit of advice and support, and we assigned an embedded researcher to undertake some work which included some interviews, and that led to some recommendations that are now being built into the service provision. So that's kind of a direct example of that evidence really being embedded now into those services. Another example that I'll just highlight is around the Remake Learning Festival. So the team wanted to build on some of the previous evaluation methods, which would inform the way that the festival and the skills sessions are provided in the future. So they approached the HDRC team again. We worked with them to review and update the existing evaluation methods that they use to enhance the quality of that information. And that's led to another piece of work where we are jointly developing a research plan with them to be able to undertake some more in-depth research into the impact of that locally for Doncaster residents. I mean, there's a number of different examples. We've just started some work with the Complex Lives team as well that will really kind of look into some more of that kind of understanding around the outcomes for those that are presented with homelessness. And it's worth noting that all of these, or most of these projects, really do involve that element of capacity building, where we are upskilling colleagues in undertaking projects, and to be able to build that confidence to be able to use sort of research skills and those evidence-informed approaches. Okay, so this slide really demonstrates what we've done so far in terms of those collaborations and funding bids that we've applied for. So the ability to bring in funding is part of developing a sustainable HDRC and sustainable research activity in the council. So you'll see on there that so far we've got a successful application rate of about, exactly 50%. That is higher at the minute than what's generally considered good. I think it's 33% is usually kind of considered as a good rate. So at the minute, that's going pretty well in terms of bringing in some of those funding. And anything that isn't unsuccessful, it doesn't necessarily mean that that's sort of, right, that's done and dusted. That can be, we can work more on those internally. So we've got a range of different bids that have been led by the HDRC team, or where the HDRC team have been built in as co-applicants. But we've also had some applications where council staff or elected members have been in as co-applicants. And we've got more of that type of applications that are being scoped out and developed at the minute now. So that will increase. So that really does give others an opportunity to really upskill themselves. So this is the final slide, just focusing a bit around how we motivate people to get involved. So the beginning of next week, we will softly launch what we're calling HDRC Help, which is basically our version of a research and evaluation support service, which will provide a single place for colleagues to go for information around training and development opportunities, useful resources and guides, and a place to be able to submit those support requests, queries and ideas, or if they've, thinking of something that they spotted in practice, but they just want to have a chat with one of the team to understand a little bit more further about the potential to deep dive into that. That's where that will all come under, and that will be under regular review and improvement. So we'll keep kind of building on that. Obviously, training and development will be a key way of bringing people in. We've currently got a training and development needs assessment out, which will inform what our provision looks like. And we can also signpost to sort of external opportunities that have got funding attached to them as well. Obviously, underpinning all of that, we've got our communication strategy, which is developing. And those sort of introduction sessions, we've done place-based events in the conference. And we really are building that sort of web presence and pushing or starting to promote that offer that we've got to officers. And Susan's already talked about the embedded researchers that really do bring a lot of enthusiasm, skill in spotting research opportunities in sort of some of the everyday conversations. And I think that's yeah, that's just brought us back to the recommendations and any questions.
Lovely, thank you ever so much. We've got one question. Would people like to put their hands up if they want to ask a question? So we've just got Sarah and Phil, thank you, and then Nabil, thank you.
Thank you so much, both of you, for that fantastic presentation. And it's, you know, as the recommendation says, you know, to champion what you've just said. And absolutely, I'm a huge advocate for sort of embedding more research into local government, because people, as you said earlier, are already doing it. They just don't really know, like, we don't have the structure or the support to get it to the next level in which we can really use that to get more funding to support and build different sort of innovations or help provide better prevention and things like that. I also think, you know, there's lots of great evidence already out there about how having a culture of sort of upskilling your staff in research skills enhances, you know, retention, and it actually makes you a really positive place to want to go and work. It brings that kind of reputation, which is something that I think will only be fantastic for Doncaster residents, but also the council as a whole. I had a few suggestions. Like, obviously, one of the good things about research is I'd be really pushing for us to use methods that are fully co-produced and using co-production authentically with the people that we're working with. So whatever that project is with our residents or the people accessing that service. You know, I do think we're already kind of doing a lot of really interesting methods, and it'd be great for our staff to be able to share them in kind of fun, short ways. So like when I worked at Leeds Hospital, we used to, every Friday, we would have a breakfast learning research session, and everybody would go because there would be breakfast. But I learned so much there, and it was just a brilliant way to connect people together. It made you feel like it was doable, and really brings up morale, and you get to celebrate some fantastic work. And I don't think we get to celebrate the fantastic work that officers do in all different ways. And I would recommend, it'd be great. We just had the Festival of Practice just before Christmas in adult social care, which was with all our fantastic social care staff. And being able to showcase some of those methods or work that's happening and encouraging people that research is practice and practice is research, and just kind of encouraging that you can use that reflective cycle of your practice to make better outcomes and for everybody. So thank you very much.
Can I just come back on that? Thank you. That's really, really helpful. I'm completely agree with you about the idea of doing more showcase type things and people seeing other people doing it, because you kind of got to see others doing it that are like you, to realise that you could get involved in this and that you could be research curious. So yeah, we absolutely intend to do more of that. And then just to sort of emphasise that point you've made about why in difficult times you might want to be involved in research, it does help with recruitment, it helps with morale, it potentially helps with burnout. We were doing some negotiations with the What Works for Wellbeing Centre about actually undertaking a research project around that. Sadly, their funding has ended and they're closing in April, which is bad news. But our contacts there are keen to carry on working with us around this, because they can kind of see the palpable buzz that you can have about being involved in research, and how that can really make a difference to daily work and increase standards and all of those sorts of things. So one of our opportunities over the next 5 years is to actually evaluate the impact of things like the HDRC. So we're really up for doing more, and the more creative, the better. Thank you.
Thank you. And Phil?
Yeah, it's really it's really helpful, this. I just wanted to ask a question about how you think kind of leaders in health and care can do a bit more in this space. Because I kind of feel like, you know, you've done a great job, and Rupert's done a great job building this infrastructure, and we probably don't know how lucky we are in Doncaster to have it. But I kind of feel like I need to do a bit more to sell these opportunities to my staff, and I think that probably the percentage of people who really think that whose lives light up when they think about research is probably quite small, because that penny hasn't dropped there, because people see research as work and they see it as distraction from day job, which is exactly the wrong mentality, but we've driven that mentality into them in our services over years and years. So I suppose, as I said, the question is, what more you probably need to challenge and maybe support us in thinking as leaders, how do we get this to stick? Because otherwise it might come and go. We might not have had the impact we'd have wanted.
It's a great question, Phil, thank you. I think one of the things is that, obviously, as Caris mentioned, we've done a survey to staff across the organisation about their training needs in this arena, and there will be a whole programme of training opportunities to get involved. And some of what senior leadership can do is give people permission to be involved in those things and actively champion that through our PDR processes and so on. So that's a really practical thing that can be done. And then I suppose the other thing that one of our recommendations is that we'd really like to do a research priority exercise through this board and through other parts of the council, so to actively be part of that. And I suppose the final thing is to, as we launch HDRC Help, is come to us with puzzles and questions and participate yourselves if you're able to.
I think that's really helpful, but I also think that that kind of idea of leaders giving permission is probably just a little bit passive. So I feel like if I was going to land this properly in adult social care, it would need to feel like an absolute priority, because we won't retain staff, we won't develop our services unless we actively are engaging with this, rather than seeing it as something that we give permission to the really interested people to do. So it's just that sort of challenge I think we probably need to get across into our leadership.
Thanks, Phil. That's a really useful pushback to us in terms of being passive. But I suppose there's something about leaders using the levers in the system. So obviously from a social care perspective, it's a pillar of practice, isn't it, being involved in research? There's levers around CQC, being interested in being involved in research, so it being an absolute must. I suppose there are mechanisms that we can have within our workforce strategies that for professional groups within the council who ought to be involved in research, that it's part of their lever to next stages or part of those sorts of processes. So to use some of those mechanisms, but I think it's a really useful challenge, and we need to think more about our ask and what we can really want you to do in this space.
Thanks, and just to echo the comments elsewhere, and actually the conversation between Phil and Susan's helped as well. I think from my point of view, in the example you gave about the drug and alcohol services, that sort of brings it in a bit to life, actually, what kind of things this looks like. And probably, I guess, my real interest would be, can we use this resource, and are we already doing it, to do some stuff around differential investment around with the health inequalities lens? So I think that's something the NHS hasn't really got into, but it does feel like it's needed. And is this actually an opportunity to do that? And happy to have a conversation. Because if I give an example, sort of when the primary care networks came, that's remained very much on an investment in terms of money and staff, has become on a population number basis rather than on an actual needs kind of basis. And is this a way to move from A to probably where we need to get to, particularly in the context of budgets and things like that?
Really helpful observation there, Nabil, and really happy to have a chat to you in terms of the detail of how we might go about supporting something like that.
I think some of this has come out in the discussion, and it was certainly in Susan's introduction as well. Anybody that's ever worked in the NHS, research has been kind of a core part of the work that they do day to day. Moving to local authority, that's been less so, I think, and that's what the principles around this additional investment is for. I think it's right about thinking, how do we make that as a broader sales pitch to all of those who could benefit. I've talked to Susan before. We've got a lot of learners in the public health team about having some kind of conference over the next year or so called something like What Does Public Health Do Anyway? But I think maybe we can fix and pitch that up a bit more to present it as opportunities for broader involvement in research, using public health examples and some of the broader examples that we'll have through the year of when other professionals and other teams have been involved with HDRC work. I did just, Susan and Caris have brought out lots of positives in what is just the first year of HDRC so far, and I just wanted to highlight another few as well. And the other one is around, as we've been able to demonstrate capability around research and capacity around research, that's a real positive to other potential research funders as well. So we've seen examples of it actually being a bit of a magnet to additional funding, additional focus. So I know you mentioned that a little bit, but wanted to highlight that too. And the other part, yes, skills and retention as well. We've been able to attract what's been a real mix of talent into HDRC. So people that would have never come to work in a local authority or never come to work in a public health team before, bringing all of their skills. And I've had some really interesting, inspiring conversations with those, and that bit about how do we make that opportunity broader and wider as well to inspire that, well, that desire, or actually this can be part of my job type element too.
Thank you. So I was going to sum up because I can't see any other hands. I think you asked us the question about do you want to find out from us what our priorities are in terms of research. So I think everybody would be happy to support that and obviously work with Louise to achieve that. So we can, as a health and wellbeing board, identify. For me, I think, picking up what Phil said in terms of not being passive, we heard from Claire earlier that we've got some long-standing challenges. You listed 5 or 6. So I would hope that in terms of research, that's something that we can try to understand. Why have we got such poor healthy life expectancy in certain, for both men and women, when we shouldn't have? Why have we got these issues in terms of the child accidents, etc.? So I think I would hope that we're actually linking in, and as I can only speak for the council, but we've got an amazing opportunity here. We're only one of 4 in Yorkshire and Humber and one of only 36 in the country. Yes, we've got another 4 years to go, but we surely, as all leaders, should be, every time we do something, think, would research be able to help us with that? And clearly it needs to link into the fairness and wellbeing outcomes. So our session on the 9th of February, I would hope that we think about research. What do we need to know more to be able to improve the health and wellbeing as we need to? Are people happy with that? Because I just think it's, you came and did the presentation. Yes, we've had a year, but, we're not celebrating enough the amazing research that we could have done, but also what we've got the potential to do. And I love Sarah's idea, almost like, the breakfast sessions. If they were on Teams, I know you don't get your breakfast, Sarah, but at least people can actually find out what other people are doing. And for me, having worked in services for years, the fact that I could actually do some research to get to the bottom of what some of the service issues are, we as a health and wellbeing board really need to grasp. And I'm happy to send something out to that effect after this meeting, because across all sectors, it's not just the council, we really need to utilise it. Did you want to come back, Susan?
Just to welcome that. I mean, one, I think from the development event that you've got on the 8th, it would be really useful to have that question in mind about how could research help this, could it? And then we can have some conversations around that. And then secondly, the offer to write out and to talk about that being in the question. And maybe that's actually what I should have said in Phil's response, that's the leadership we need, really, to be thinking about how could research help in this. It's not always the answer, it's not a magic bullet, but it's that kind of thinking in all we're doing that would be really helpful. So thank you, I appreciate that.
Okay, so I'm happy to take that as an action, but then individually people think about what they can do as well as. Okay, so have we answered those recommendations? The champion, the evidence informed. We've obviously talked about linking into the health and wellbeing strategy, opportunities to update members. Yeah, I think as well organisations need to think, how can Susan, Caris and her team come in to talk about research? And then we've said yes to that priority research for the board. And obviously we look forward to completing whatever survey you send out to us. Is that okay with everybody? Okay, thank you very much, both of you. So we're going to move on to item 9, which is the final item, health needs assessments for people from an ethnic minority background. And we've got Marie, Natasha, but no Victor, I see.
Yeah, just wait for Jonathan to get the slides up. But yeah, unfortunately Victor couldn't be here today, but I've been lucky enough to work closely with Natasha and also Laurie in Policy Insight and Change on refreshing the needs assessment. So thank you for all your support. Thanks, Jonathan. So there's lots of detail in the main report, which I'm sure you'll be pleased to hear. I'm not going to go through now, but I'm just planning to give you a quick overview of the needs assessment, what we've done, what we found, and what the next steps are. Is that working? Oh, it's gone too far. There we go. So the previous needs assessment for people from an ethnic minority background was carried out back in 2016, 2017. It's obviously a lot has changed since then, not least the formation of our Minority Partnership Board and all the work that it's overseen during COVID and beyond. And in terms of data, most of the census data from 2021 was only published at the start of last year, so it felt like a sort of timely moment to revisit our assessment. So the aim was to provide a sort of comprehensive update of our understanding of the health needs of our ethnic minority communities, to see what's changed, both from the last assessment and the last census, and for that to then inform our work plan and the sort of wider development of services across Doncaster. As I said, it covers just the census data, but also data from the council and from system partners, as well as the views of some of those communities themselves. And there's some context in the report, again, about the work that we've sort of been undertaking over the last few years and some of the national issues, just as context setting. So just a quick overview of the demographics from the census data. So I guess that the headline is the number of residents from an ethnic minority background in Doncaster has continued to increase. So we're at around 41,000 people. Generally got a younger age profile than white British residents, with the exceptions of the Black Caribbean and white Irish communities. The majority live in central areas of Doncaster, and there are some maps in the report which give a bit more detail. And then just, I think one thing that's important to note, there's some crossover in terms of migration. So this isn't a needs assessment of migrants, but a significant proportion of people are relatively new to the UK, and this might, they might have additional needs in terms of navigating and accessing our services, which we should bear in mind. Again, more detail in the report in terms of the breakdown, but this is just to highlight the diversity of communities that we have in Doncaster. So Romanian and Polish are our two largest groups, and it's a slightly different makeup to England because we've sort of proportionally got more people from these white ethnic minority backgrounds. But saying there's more detail in the report if you want to look through. Moving on to some of the health and wellbeing data. So there are two key measures from the census that are your self-reported health status and self-reported disability. I'll talk about health as an example, but the stories for disability is fairly similar. So most ethnic minority groups have better health than white British groups, with the key exception of the Gypsy or Irish traveller community. But this data is not age standardised, so it doesn't take into account the fact that these groups tend to be younger and therefore have better health. So if you adjust the data to take into account their age, we can see sort of two things. I guess firstly, the health of all ethnic groups in Doncaster tends to be worse than England on average, which we know. And within Doncaster, there are then some differences by ethnicity in terms of people rating themselves as having bad health. So there are issues to look at once we adjust for age. Other data, this is the first time we've been able to include sort of health service data, which is really good. So we've got things in terms of access to secondary care and mental health services and long-term conditions. There's still a few caveats in terms of the data, but I think it's a really good starting point, and hopefully we'll be able to keep building on that with some more sort of granular data over time. Other health data we've been able to include, so there's some stuff in there around COVID-19 and vaccinations. As I'm sure you're aware, there's lower uptake among ethnic minority groups, but actually compared to South Yorkshire, we've done quite well, which I think reflects a lot of the targeted engagement work that Natasha and colleagues sort of undertook during the pandemic. We've tried to have a bit of a focus on children and young people, pulling together what data we can. So we can see some differences in terms of low birth weight and childhood obesity, which I don't think we've picked up on before. And we've also got data from the latest pupil lifestyle survey. Key things that showed were lower rates of dental access among pupils from an ethnic minority background, and higher rates of smoking, alcohol and drug use. We couldn't get access to childhood vaccination data by ethnicity in time for this report, but it is something that's collected, so I think it's something that would be good to include in the future. And then there's a final section in there around wider determinants, mainly drawn from census data, but is helpful in terms of context. Then the other main section of the needs assessment is based on community engagement. So Natasha and her team carried out a series of focus groups during the first half of last year with representatives from a number of different ethnic minority communities, produced some really, really rich data and insights, which again, won't have time to go through now, but there's a sort of 3-page summary in the report. And one of our embedded researchers in the HDRC also did a sort of further, more detailed write-up, which we can share with anybody who's interested. I think you'll probably recognise a lot of the themes from Claire's presentation. It's not surprising that these are sort of shared issues, but there were some specific issues for ethnic minority communities, I think particularly around language and translation and that cultural awareness and accessibility of services. And I think that's something, we'd want to pick up on in the specific action plan for this. So that was just a really quick tour of the main content of the report. 4 very high-level recommendations. So the first is to develop a sort of detailed action plan to address the issues highlighted, and I'll come back to that one in a moment. The other 3 are around data, so building on the progress that's been made in terms of access and sharing between organisations, and that actually collecting the ethnicity data and improving that quality in the first place. Then around communication and engagement with our communities, and a more strategic point around ensuring the needs and these priorities are taken into account, so particularly in terms of the health and wellbeing strategy and the 5-year plan. We'd have, I guess, a few asks of the board in terms of these recommendations, so we'd like your support in endorsing the recommendations and to provide oversight in terms of their implementation, particularly when it comes to the action plan. And we'd like to ask individual members and your organisations to help contribute to delivering them, where you can. And please do share and use the report if it's helpful. It's not just for the council, but it's there to support the wider system. So just to come back to that first recommendation around the action plan, we've shared the detail of the needs assessment, and it's contributed to the sort of synthesis of resident engagement for the health and wellbeing strategy and 5-year plan. And then we, Natasha and Romana, have started developing the action plan. So the intention is to use the kind of headings there based around the themes and findings from this report. So the Minority Partnership Board have agreed to have a stakeholder workshop to help kind of develop the plan further and to agree who's going to take ownership of the different actions. Because, it's not a council-owned project or piece of work. We really want to work cross-system. We still need to confirm a date for that workshop, but again, we'd appreciate your advice and thoughts on who you'd like to attend from your organisations. So if you could let Natasha or Victor or Jonathan know, that would be really helpful in the next couple of weeks, so we can get the date firmed up. Natasha, do you want to say anything more about? I think you've covered it all. Yeah. Or was there something around the co-production side?
In relation to the action plan?
Yeah.
Yeah, so as Marie said, we're going to be holding a stakeholder event within the next couple of weeks. And for those of you that have had a chance to have a look over the data in terms of the themes and the health needs assessment, obviously that is going to be the basis of the action plan. So if people could have a bit of a look to see who might be the best lead from their organisation to attend this stakeholder meeting, that would be really good. Also, just to say in relation to the action plan, we've had some specific ethnic minority communities that we consulted with, such as the Chinese community and the African community, ask that their specific sections of the action plan be co-produced, which is always part of the offer. So I'm going to be going out to speak to them within the next couple of weeks to say, this is what we think you said, and actually this is what we'd quite like to do about it, but how do you feel about that, and how do you want to help to shape that? So yeah, we're really keen to get the action plan right. I think what we were probably missing in previous years in relation to action plans that we've had was that SMART element, which we're really keen to change this time. And I guess one more request for this forum to say we'd like the oversight of the action plan and its progress to remain here, if that's okay, and to come back at regular intervals to be able to update you on that, on progress and in relation to any pinch points that we might be experiencing. Thank you.
Thanks, Natasha. I think that's everything I wanted to share, so happy to take questions.
Okay, thank you ever so much. So we've got Nabil. Anybody else that wishes to come in? Phil, and then I've got a few points as well. So let me write them down. Nabil, Phil, Sarah. Okay, over to you, Nabil. Thank you.
Yeah, thanks very much. Very, very comprehensive and well presented. A couple of things, I guess, about cross-referencing and other things we've talked about. So I think it's really helpful when you see the breakdown of things and then age looking at it via age as well. It changes the emphasis on it. So I think there'd be something there about looking at some of this data and then looking at it by male and female gender, pick up some of the points we've talked about here. Actually, is it a female healthy life expectancy across all ethnic backgrounds? Is it a white British thing? Is it within certain communities? So I think we need to do that if we haven't already. And then the second thing was just around specifically the flu uptake side of things. So again, is that a ethnic minority difference, or is it a poverty difference? So we know the majority of the poverty is in the central, the majority of the deprivation is in the centre of Doncaster. Is that where the flu gaps are as well? Or is it actually we need to do more of that community outreach, things that we did through the pandemic?
Thanks, Nabil. So on the gender breakdown, we can certainly look at, I think Laurie might have already done so for the census data. In terms of the health service data, we don't have access to that data ourselves, and I think that's one of the areas it would be good, again, to work on partners with in terms of improving that granularity so we can do that analysis. In terms of flu uptake, I think there has been some work looking at that. I think nationally there definitely is a difference on ethnicity, even when you adjust for deprivation. Locally, I'm not sure whether we're able to have looked at that data, but Rachel might be able to say something more.
I was going to add words more than data just around that, and Natasha will have some of the detail as well. Using COVID vaccination as a proxy for flu vaccination, I know they're different. We knew that it needed a different approach with some communities and often ethnic minority communities for that extra level of assurance that they might need, and some quite practical questions around, as well around content of vaccinations. We often have to offer assurance around as well for porcine content. So there's some of that factual assurance, but also norms in different communities as well, and expectations. So I think as well as there being a layer of deprivation that possibly has an impact on probably all vaccinations as well as flu vaccination, I think there is a specific layer, or it feels from the work that's been done previously, there is a specific layer as well for people from ethnic minority backgrounds.
Thank you, Rachel.
Can I just come in just on that back? Yeah, so that's really helpful. I guess what would then be interesting to see is, have we built trust with those communities from a vaccination point of view? So does the data actually look better within those communities than it did 5 years ago, for example? So again, I think that's the thing. Or do we have to do more to build trust with those communities we can build trust with?
Did you want to answer that question?
I just wanted to come into that just from the point of view that that's a research question, isn't it? And I think that's one of the things that's really interesting about Natasha's continued involvement in this. Not only does it help with continuing contact with communities, but it also helps us understand where some of the research questions may be, when we can spot gaps in the data. And that is some of the role of the embedded researchers, to listen to some of that conversation and go, actually, we might be able to do a little bit more work in that area. So it was just such a lovely example. I couldn't resist jumping in.
Absolutely brilliant. Thank you. I've got Phil and then Sarah.
Yes, this is really well timed, isn't it? Because there was a Team Doncaster really powerful session yesterday around anti-racist practice that most of our organisations were represented at. And we were given a really clear 10-point plan to address promotion of anti-racist practice across all of our organisations and as a partnership. And we were given homework to do and a point to reconvene, I think, on the 20th of March. So I suppose my question is, because a lot of that will add a lot of power to this, but it doesn't feel quite connected the way we describe this. I suppose my question is, how can we make those two things reinforce each other? Because it's a great time to have this conversation and to make sure it's reinforced with yesterday's.
Yeah, thank you. So I was at that event yesterday, and there definitely are linkages in terms of this piece of work. I think what myself and Arshad can do, because Arshad's heavily Arshad Khalik, who's heavily involved with the Minorities Partnership Board, but obviously had a lot to do with facilitating and coordinating yesterday, is to look at these two pieces of work together through that kind of lens to see how they can complement each other. So we can get on with that before the next Minorities Partnership Board, and definitely before we update at this meeting again.
Thank you. And then Sarah.
Thanks, Chair. My question was basically an amalgamation of all of this. So we did have the sort of anti-racism workshop yesterday, and Natasha, you mentioned that you're going to be co-producing this, and I was thinking, with my research hat on, that all of these elements need to come together, and we need to connect them better and be able to use real authentic methods to co-produce and understand some of the drivers and how to make things better and more equitable with a multitude of different communities, and understand it, like Nabil said. And I don't think it's like, it's all very data-based, this. And I think what's missing is that kind of more humanities, qualitative understanding of that as well. So it'd be good to be able to connect all of that, and I think that'd be something we can use this board to keep a track of and join together.
Yeah, I know Victor wanted to join today and hasn't been able to, and has been working with Natasha Marie around this, and is also core part of all of those other elements, the anti-racism training, the ethnic culture fusion network, all of those elements as well. So what we'll do between the three of us is give a bit of a précis today on the conversation as well, through to Victor as well, and ask him to have some thoughts and come back around those elements of linking together. And sorry, I know I'm sneaky doing this, just on recommendation 2 as well, which is around that data and quality of data and use of data. When reports like this are created and subsequently decisions are made following reports like this, it's all based on the quality of data that's there. Recommendation 2 around quality and use of data was one that came out of COVID, and I'm pleased to see it in our local recommendations as well. So really one for health and other partners, and I know systems have improved as good a quality recording of data that we can get in healthcare and other institutions will mean that when we get data through to look at and dig at what we really need to do, that's a real vital recommendation from the report.
Definitely. I can't see any other hands. What I'm really keen to see in this is that we understand where the gaps are. So we understand where the gaps are in data, because clearly there are some now. And I think we need to understand the gaps in services. So we obviously, we had a previous meeting, Whitney and others talking about translation services. And I think it's something that we almost skirt around, but I'd really like to see in this report, this is the current picture. This is how people can access translation interpretation services, but using qualitative information to understand, is this enough? How does it actually meet people's needs? Because my anecdotal view at the moment is that it doesn't. You know, we've had Pauline attending this group from British Sign Language. Same issue with that in terms of translation. It's not enough. And I think in this report, we need to be really honest to say this is the current position and where do we need to go to. So I think that fits in with recommendation 2, that we've got to really be honest and go, we don't collect this data. We should, but we don't. But how can we actually do it? And then I've got some couple of other points and questions in terms of, have we got the Minorities Partnership Board, and I attend when I can, Natasha knows, have we got the right people at that board who are feeding into their organisations to make the system change that we're going to need to make if we're going to deliver on what the training was all about yesterday? And I don't get a sense, I don't see those linkages, so I think we need another report or another, part of the report to say, have we got those linkages? Have we got the right people engaged? Because if not, as a collective, then we need to look at it. I think that's the first thing, because we're never going to bring about the change that we need unless it's been discussed at the right level. And I don't get a sense at the moment that it's not. I get a sense at the moment that the level perhaps isn't quite right. The Minorities Partnership Board, incredibly vibrant, dynamic, lots of discussions. But I often leave thinking, and how's that then going to influence, for instance, what the hospital's going to do or what the ICB is going to do, etc. And I think we've got to be really bold, and I think somebody picked up on the targets need to be smarter. We need to be really bold with this and go, we expect X, Y, and Z to happen, and then we're going to monitor that. We're going to measure success. And then if it means coming to this board in a year's time and going, actually, we've failed on these measures, and these are the reasons why, we need that honest and open discussion, which I don't think at the moment. We've almost, and I'd want the recommendations in the report to be a lot more assertive, not passive. Assertive. We had 50-odd people yesterday at the anti-racism training. There's clearly an interest, and we need to capitalise on that, rather than have a report that says it might be a good idea too. It's got to be about, this is a must, because if not, we're failing, 13% of our population, which is completely inappropriate. So in terms of the recommendations, I think people are generally saying they support them, with my added things that I'd like to see. In terms of action plan, because that's the crucial bit, isn't it? Whether it's co-produced and I would really encourage it all to be co-produced. When's the next steps that we, because I think everybody's happy, Natasha, that we maintain oversight of this, and perhaps as leaders get a little bit more involved or direct our officers to get more involved. So timescales for next steps.
Yeah, that would be great. So within the next month and a half, the action plan will be completely pulled together. We've got the bones of it, as I say. It's just sense checking some of that with some of the communities that want to do the co-production bit. And as you say, it may be well worth going out to, or putting the ask again out to the other communities to say, this is how it could work in terms of co-production. Do you want to take us up on the offer this time? That feels appropriate.
I know I'm putting it on the March agenda, and Louise will look at me as she just did then, but I think it's so important that we get this ready. Phil?
It might be something that you wanted us to discuss in February, because I think that there are different schools of thought, aren't there? Some people will say, focusing on the 13% detracts from the wider blah-de-blah-de-blah. No one's saying that in this room. What other people might say is that if we do anti-racist practice well, we will be doing everything well. So there's something about, are we a health and wellbeing board that's going to put health, anti-racist practice at the centre of everything we do, or are we going to be a health and wellbeing board that sees it as an item that comes every now and again? So it might connect with the February discussion.
Okay, unless anybody's got any other points. Thank you ever so much, everybody, for the presentations. I look forward to seeing you in March the 7th, and it will be a long meeting, so be prepared. Thank you ever so much.